Welcome to the deep dive, where we crack open complex information and really distill it into clear, insightful nuggets for you.
Yeah.
Today, we're diving into the fascinating world of hematology.
hmm
Think of it like learning the secret language your blood tests are speaking, especially when it comes to understanding anemia and what a hemogram can really tell you.
Right. Our mission today is basically to give you a shortcut. We want to help transform what might just look like a jumble of lab numbers,
Yeah, just noise sometime.
exactly,
Yeah.
into a clear, compelling story about your body. We want you to walk away from this deep dive, not just knowing what anemia is, but really getting the different forms and, maybe most importantly, why it happens.
Absolutely. And we've pulled together a really comprehensive set of sources for this deep dive, guiding us through assessment, intervention, all that stuff in hematologic disorders.
hmm
So let's unlock this blood language for you and make some real sense of it all.
Let's do it.
So let's start right at the beginning. When we talk about anemia, what exactly are we referring to? What's the core definition?
Well, at its heart, anemia is a condition marked by a decrease in your red blood cells, your RBCs,
Yeah.
or a reduction in the amount of hemoglobin they carry. And hemoglobin, it's vital to what gives your red blood cells their color, and more critically, it's the molecule that carries oxygen all through your body.
Okay, so less oxygen transport, essentially.
Pretty much, yeah.
And what's causing this decline then? Our sources point to a few main reasons, almost like different pathways leading there.
Exactly. And figuring out the cause is the absolute first step in, well, any effective treatment.
Hmm.
We generally look at three primary mechanisms.
Okay.
The first is chronic low-volume blood loss. Now, this is often incredibly subtle, something you might not even notice.
Like what?
Well, we're talking about things like erosive gastritis, causing tiny internal bleeds or heavy menstrual periods, or even a gastrointestinal malignancy. It's significant because the iron from those lost red blood cells, it just can't be recycled.
Ah, okay.
And over time, this leads straight to iron deficiency anemia. I mean, think about it.
Hmm.
Losing just a few milliliters of blood each day
Mhm.
consistently, that can be clinically significant.
Right, it's like that slow leak in your tire you don't spot right away.
Exactly like that, yeah. Then the second big mechanism is reduced red blood cell production. So your body simply isn't making enough new cells.
Okay, production issues.
Right. This can stem from common nutritional deficits, maybe not getting enough vitamin B12, folic acid, or iron.
Mm-hmm.
It also includes conditions like anemia of chronic disease, where underlying inflammation kind of suppresses RBC production, or issues with your bone marrow itself, or even reduced erythropoietin production.
Hmm.
That's the hormone-stimulating RBC creation, which you often see in chronic renal failure.
Right, kidney problems affecting blood.
Exactly. And what's really fascinating, actually, is how some common medications, like chronic use of proton pump inhibitors, PPIs for acid reflux,
Yeah, lots of people take those.
or metformin for diabetes, can actually prevent your body from absorbing these vital micronutrients. So you end up with B12 or iron malabsorption because of the meds.
Wow, okay. Didn't know that.
Yeah. And then the third mechanism is premature destruction of red blood cells. The technical term is hemolysis.
Hemolysis. Got it.
Now, while it's not as common as the other two in primary care, this just means your red blood cells aren't living out their full lifespan. Normally, they stick around for about, say, 90 to 120 days.
Okay.
But in hemolysis, they're destroyed much, much faster. And this shortened lifespan, it also plays a role in anemia of chronic disease, too.
That's a great breakdown of those three main pathways. But what about something more sudden, like, say, an acute injury or, significant bleeding all at once? Is that the same kind of anemia or is it a different picture?
That's an excellent question.
Yeah.
And yeah, it is a distinct category. In adults, it generally takes at least a liter of acute blood loss before you see a really clinically significant drop in hemoglobin.
A whole liter. Wow.
Yeah. And when it happens acutely like that, the signs are usually pretty unmistakable.
Yeah.
You typically see things like dizziness, a rapid heart rate, tachycardia, and lower blood pressure.
Mm-hmm.
It's not that same kind of slow, subtle drain we see with the chronic low-volume loss.
Right. Much more obvious. Okay. So just to recap the kind of aha moment here then, anemia isn't just one simple thing.
No.
It's often this hidden signal telling us something deeper is going on, whether it's that subtle leak, a nutritional gap, or even how our meds are interacting with our system.
Exactly.
It's really a symptom, not just the diagnosis itself.
Precisely. It forces you or your doctor
Yeah.
to look beyond the surface.
Okay, so if you or your doctor suspect anemia, the next step is usually that blood work, specifically a hemogram. Now, looking at these reports, honestly, it can feel like staring at a foreign language, so many numbers.
Oh, absolutely.
But our sources give us a fantastic framework for kind of decoding them. What are the key metrics, the things that really matter on that page?
Okay, yeah, this is where it gets really powerful because the hemogram is like your ultimate diagnostic tool for categorizing the anemia. We're essentially looking for the red blood cell's fingerprint.
Right.
So first you'll see your hemoglobin, HB, hematocrit, HECT, and your red blood cell, RBC count. These are your initial indicators. In anemia, these numbers will all be proportionately decreased.
Okay.
A handy rule of thumb is the hemoglobin to hematocrit ratio, the H&H. It's usually about 1 to 3. So if your hemoglobin is, say, 10 GDL, you'd expect your hematocrit to be around 30%.
Got it. 1 to 3.
Then we get to red blood cell size.
Yeah.
This is measured by something called mean corpuscular volume, or MCV.
MCV. Okay.
Think of your red blood cells like a fleet of vehicles. The MCV tells us the average size of those vehicles. If your MCV is less than 80 femtoliters, FLO, your cells are microcytic, like little compact cars.
Micro, small. Makes sense.
Right. If it's between 80 and 96 FL, they're normocytic standard sedans, normal size.
Okay.
And anything greater than 96 FL means your cells are macrocytic, more like minivans,
Right.
abnormally large.
Big cells.
Right.
Right.
And because an RBC size doesn't really change during its 90-day lifespan, the MCV acts like a very stable indicator.
Ah, okay. Good point.
Next, we look at red blood cell hemoglobin content. This shows up as mean cell hemoglobin, MCH, and mean cell hemoglobin concentration, MCHC.
MCH and MCHC.
Yeah, this reflects the color of your red blood cells, basically, because hemoglobin is what gives them their red color. Normochromic means normal color. It's an MCHC between 31 and 37 GDL.
Okay.
But if your MCHC is less than 31 GDL, they're hypochromic. They look pale.
Hypo, less color. Okay.
And here's a really key tip from our sources, super helpful. Small red blood cells are always pale red blood cells. Microcytic means hyperchromic.
Oh, interesting. They always go together.
Always.
Yeah.
And finally, there's the red blood cell distribution width, or RDW.
RDW.
This one's really interesting because it's an index of the variation in red blood cell size. How much difference is there between the smallest and the largest cells?
Ah, okay. Not just the average size, but the range.
Exactly. Normally, there's a variation of about 11.5 to 15%. An abnormal RDW, meaning higher than 15%, tells you that your new cells being produced are differing significantly in size compared to your older cells circulating.
So something's changing in production.
Precisely. It's often one of the very earliest laboratory indicators that a microcytic or macrocytic anemia is starting to evolve. It's like suddenly seeing a mix of tiny smart cars next to huge trucks in your fleet.
Yeah.
Something new is happening.
Right. Okay, so these markers aren't just isolated data points then. They're like pieces of a puzzle that, when you put them together, give you a much clearer picture.
Absolutely.
It's less about memorizing individual numbers and more about seeing how they all relate.
Exactly. For example, if you're developing, say, microcytic anemia, as your MCV, the average cell size, starts to drop, your RDW, the variation, often goes up because you're introducing these new smaller cells into the mix with the older normal-sized ones.
Okay, the variation increases.
Right. And the same thing happens in an evolving macrocytic anemia. As the MCV increases, the RDW will also likely increase. They tell a dynamic story together.
Got it. And what about reticulocytes? I remember seeing that term. What role do they play in this whole picture?
Right. Reticulocytes. The reticulocyte percentage measures the number of young, sort of immature red blood cells in your blood.
The new recruits.
Exactly. In a healthy person, it's usually only 1–2%. It's basically your bone marrow's response to the demand for new red blood cells. So if you're anemic and your body is trying to correct that anemia, you should see reticulocytosis, which is an increase to over 2%. It's a crucial indicator. It tells us if your bone marrow is responding appropriately to the anemia or if maybe the bone marrow itself is part of the problem.
Okay, so it shows if the factory is trying to ramp up production.
That's a great way to put it, yes.
So the big insight from this segment then is that a hemogram isn't just that jumble of numbers we started with.
Not at all.
Each metric is a distinct clue size, color, variation, even the new recruits. And together they form this kind of blood cell fingerprint, guiding us directly to the type of anemia we might be dealing with. It really is like a diagnostic map.
Absolutely. It's what transforms that raw data into, well, actionable medical insight.
Okay, so now that we've learned how to decode these individual numbers, the MCV, RDW, all that, How do they actually come together? How do they help us identify the specific type of anemia? Our sources laid out some really clear diagnostic patterns.
Right. This is where we connect all those dots we've been gathering.
Hmm.
The hemogram results combined with, the patient's clinical presentation, that really guides the next steps.
Okay.
So let's start with normocytic, normochromic anemia with a normal RDW.
Normal size, normal color, normal variation.
Exactly. All normal on the description front. In primary care, the most common reasons for this pattern are anemia of chronic disease-like, maybe in a 32-year-old just diagnosed with lupus, for example,
Right.
or chronic kidney disease, or even acute blood loss, like we talked about, maybe in a 72-year-old man with a sudden GI bleed.
Okay.
And here's a really helpful tip from our sources, especially for tests or just quick thinking. If your MCV, MCHC, and RDW are all normal,
Yeah.
then you can pretty much rule out iron deficiency, vitamin B12 deficiency, and folate deficiency right off the bat.
Oh, that's useful. Okay. What's next?
Next up, we have microcytic hypochromic anemia with an elevated RDW.
Small cells, pale cells, lots of size variation.
You got it. This is your classic presentation for iron deficiency anemia, IDA. It's probably the most common one people think of.
Right.
Think of maybe a 68-year-old man with that erosive gastritis, that slow bleed,
Mm-hmm.
or a 48-year-old woman with really heavy menstrual periods. The body's just struggling to make enough healthy hemoglobin because it doesn't have the iron.
Makes sense.
Plumism, which is lead toxicity, can also cause this pattern, particularly in young kids or maybe folks with industrial exposure.
Lead.
Yeah. And for diagnosis here, a ferritin test, which estimates your body's iron stores, is absolutely key. So if you see, say, a 78-year-old woman who's fatigued and has those unusual spoon-shaped nails,
Yeah.
coupled with these lab results, it immediately points towards investigating potential GI blood loss as a cause of the iron deficiency.
Gotcha. Okay, what about small and pale but without the variation?
Ah, right. That's the next distinct pattern, microcytic hypochromic anemia with a normal RDW. So you still have the small pale cells. But critically, they're all consistently the same small size.
Yeah.
The RDW is normal.
Okay.
This pattern often points towards alpha or beta thalassemia minor. It's also known as thalassemia trait. It's an inherited genetic variation.
And what's truly fascinating here, I remember reading this, is that unlike most other anemias where the actual red blood cell count is low,
Yeah.
in thalassemia minor, the RBC count itself can actually be elevated, right?
Yeah.
Even though the hemoglobin and hematocrit are low.
That's exactly right. It's a really critical differentiator. High RBC, low H&H, small uniform cells, think thalassemia trait.
Wow.
And these conditions, they're more prevalent in specific ethnic groups. Alpha thalassemia minor is common in people of Asian and African ancestry. Beta thalassemia minor is more often found in those with African, Mediterranean, or Middle Eastern ancestry.
Okay, good to know.
And diagnosis here usually involves a more specialized test called hemoglobin electrophoresis to confirm it.
Right. Okay, moving on from the small cells.
Aye.
What about the big ones?
Okay, so macrocytic normochromic anemia with an elevated RDW.
Big cells, normal color, but lots of size variation again.
Exactly. This pattern almost always points to either a vitamin B12 deficiency, especially something called pernicious anemia, which is an autoimmune type,
Pernicious anemia.
or a folate deficiency anemia. So think about maybe a 72-year-old woman with untreated pernicious anemia. She'd fit this lab profile and might also present with symptoms like peripheral numbness or tingling, maybe some oral irritation or a sore tongue, things that can sometimes be overlooked.
Yeah, neurological symptoms too with B12, right?
Absolutely. That's a key feature.
Okay, and then there was one more category about drugs.
Yes, finally, our sources highlight drug-induced macrocytosis, which usually, and this is key, occurs without actual anemia.
So just big cells, but not technically anemic.
Correct. Certain substances can cause your red blood cells to become abnormally large, but your overall red blood cell count, your hemoglobin, your hematocrit, they all remain normal.
What kind of substances?
Well, the big one is excessive alcohol intake. We're talking 5 or more drinks a day for males or 3 or more for females.
Okay.
Also, certain anti-epileptic drugs like carbamazepine or phenytoin or even the drug methotrexate. The key distinction here is your MCV is elevated, so you have big cells, but your hemoglobin, hematocrit, and RBC counts are within normal limits, and your RDW is typically normal too. No significant variation.
And is that reversible?
Usually, yes. It's typically reversible if the offending medication is stopped or alcohol intake is reduced. Though, it's usually not a reason to stop an essential medication like an anti-epileptic.
Right.
Unlike say, excessive alcohol use, which should be addressed regardless.
Okay. So the really powerful insight here is how these, seemingly random numbers on a lab report, when you understand them through these specific patterns,
Yeah.
they become this incredibly precise roadmap. They guide you directly to the underlying type of anemia, transforming this broad diagnosis into a really targeted investigation. It's almost like the blood test itself is whispering the answer.
It absolutely is. These patterns give us immense clarity. It's really quite elegant when you see it laid out.
Definitely. So once an anemia is identified and categorized using these patterns, the next crucial step is obviously intervention. So what does this all mean for treatment? And what practical advice did our sources offer?
Right. Well, the first and honestly the most crucial step always is to treat the underlying cause. You absolutely have to.
Number one, find the why.
Find the why. Exactly. So for instance, if you've got iron deficiency because of chronic blood loss from, say, an ulcer, you must address that bleeding source first and foremost.
Makes sense.
Beyond that, then yes, we replace identified micronutrients if they're deficient. So giving iron, vitamin B12, folate, whatever is needed.
Okay.
And it's worth noting, actually, that your body's need for these micronutrients actually increases during reticulocytosis, remember, when it's busy making all those new red blood cells.
Oh, right.
Yeah.
The factory needs more raw materials when it ramps up.
Precisely. And then in more severe or chronic cases of anemia, especially if there's advancing renal failure, apoic and alpha, or EPO, can be indicated.
EPO. Yeah.
This is biologically identical to erythropoietin, which is the natural hormone your kidneys make to stimulate red blood cell production.
Right.
And its production often diminishes in chronic kidney disease, especially when the GFR, the glomerular filtration rate, which measures kidney function, drops below about 49 millimin, 1.73 mil2.
Okay, so it helps kickstart production when the kidneys aren't doing it.
Exactly.
And what about some of the more practical, maybe day-to-day insights that the sources shared? Anything that might surprise a listener?
Yeah, absolutely. For example, if you're prescribed oral iron therapy, the best advice, generally, to maximize how well your body absorbs it, is to take it on an empty stomach.
Okay, good tip.
Although sometimes that can cause stomach upset, so there's a balance. And it's also important to be aware of how severe anemia can sometimes show up in unexpected ways.
Like what?
Well, it can even cause a temporary, totally benign heart murmur. It's known as a hemic murmur.
A heart murmur from anemia.
Yeah. It typically resolves completely once the anemia is treated.
It's just fascinating how one system impacts another like that.
Wow, it really is all connected. Now, while our deep dive was mainly focused on anemia and red blood cells, the complete blood count, the CBC, also includes white blood cells, right?
It does.
What's the main takeaway for listeners regarding those, just briefly?
Yeah, that's a great point. It's worth a quick mention. While red cells tell one story about oxygen-carrying, white blood cells, or WBCs, tell another story about your immune system.
Your total WBC count usually ranges from about 6,000 to 10,000 per cubic millimeter.
Yeah.
A high WBC count, which we call leukocytosis, so over 10,000,
Okay.
that often signals a significant bacterial infection. Think appendicitis or bacterial pneumonia.
Got it. Infection marker.
Right. And each type of white blood cell responds differently depending on the threat. There's a helpful mnemonic some people use to remember the main types in order of prevalence. Nobody likes my educational background.
Okay. Neutrophils.
Exactly. Neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Generally, neutrophils spike up in bacterial infections. Lymphocytes tend to increase in viral infections. Sometimes you see these reactive-looking lymphocytes.
Okay. Different cells for different fights?
Pretty much. It's another layer of really useful information you get from that same basic blood test.
Good to know. And finally, there was that really important point about certain common nutritional supplements and their potential impact on bleeding risk. That seemed quite critical.
Yes, absolutely crucial information, especially if you're heading for any kind of procedure or maybe taking other medications that affect clotting.
Right.
Nutritional supplements like ginseng, ginkgo, and fish oil, these are potentially associated with an increased bleeding risk.
Ginseng, ginkgo, fish oil. Yeah.
The usual recommendation is to discontinue them at least 7 to 10 days prior to any elective surgical procedures.
Right.
And they also need to be used with caution
Mm-hmm.
if you're taking anticoagulant medications, things like aspirin or the newer ones like rivaroxaban, apixaban, or the older standby warfarin. You need to be careful about interactions.
Definitely need to tell your doctor about those supplements then.
Absolutely.
Oh.
Always. And interestingly, our source specifically noted that vitamin D is not associated with this increased bleeding risk. That's a common question people have.
Oh, that's good to know too. Okay. Wow, what a truly illuminating deep dive into hematologic disorders, especially anemia. We've really gone from the basic definition to decoding individual lab values, understanding those complex diagnostic patterns, and even touching on intervention and other vital blood insights. It honestly feels like we've learned to speak a new language today, unlocking the stories your blood is trying to tell you.
What's truly fascinating here, I think, is how just a few key numbers on a lab report, once you understand their language,
Yeah,
can paint such a clear and precise picture of what's happening inside the body.
it's amazing.
It really reinforces that knowledge isn't just power in some abstract sense. It's personal empowerment when it comes to managing your own health.
Absolutely. Couldn't agree more. And for you, our listener, here's maybe a final thought to mull over. Considering how deeply interconnected all these different body systems are, how kidney disease or even subtle nutrient deficiencies or common medications can impact something as fundamental as your blood cell production, how might understanding your complete blood count, even just a little bit better after this, empower you to have a more informed, maybe more proactive conversation with your healthcare provider about your overall well-being next time you see them?
That's a great question to leave folks with. Thank you for joining us on this deep dive, everyone. We really hope you feel much more well-informed.